I will now discuss diagnosing sleep-related eating disorder. This is, again, the criteria from the American Academy of Sleep Medicine, the International Classification of Sleep Disorders, 3rd edition, 2014. The prevalence of sleep-related eating disorder in adults is at least 2%, if not up to 5%. This is a female-predominant disorder with 60 to 83% of patients being female in various reported series. And this is basically a young adult to early middle age adult phenomenon, but it certainly can occur in adolescence and extend into the later years. Sleep-related eating disorder is classified as a parasomnia. It involves the circadian misalignment in eating. Sleep and eating are instinctual behaviors that can become pathologically intertwined in sleep-related eating disorder, and in fact, they mutually reinforce each other. And what's very interesting is that this is not a hunger-driven disorder. Hunger is virtually never reported in these patients, and even though most of them have some degree of amnesia, they all deny ever feeling hungry, and some of them, out of desperation, will have a second dinner before bedtime, thinking that will suppress the urge to eat during sleep, but it doesn't, because this is not a hunger-driven behavior disorder. Some patients have to engage in desperate measures. One of my patients was a single mother of 3 teenage children, and she was so desperate that she paid her children to sleep in sleeping bags in the kitchen so that when she came at night to get food out of the refrigerator or the cupboard, they would tell their mothers, "You have to go to bed." Well, she was so frustrated by their children following the orders and being paid to give the orders that my patient paid her children even more money so they can go back to bed and allow her access to food. So even though there's so much distress related to the eating and its consequences, the denial of access to food is even more frustrating. And that's a curious phenomenon as well about sleep-related eating disorder. Sleep-related eating disorder is, at least in 50% of the published cases, a nightly phenomenon. So at bedtime, they all feel like, yes, tonight I will not eat. And there's like this New Year's resolution, positive feeling. And then in the morning, when they realize that they have engaged in eating again, there's tremendous dejection and depression because once again, they have lost control over eating during the night. So for diagnostic criteria, you have to have recurrent episodes of dysfunctional eating that occur after an arousal from sleep during the main sleep period. And there should be at least partial loss of conscious awareness during the eating episode with subsequent impaired recall. With the recurrent episodes of involuntary eating, these are the problems presented by patients when they seek medical attention. Number one, by far, is excessive weight gain and obesity. Up to 50% of patients meet a BMI criteria for being overweight or obese. Also, destabilization or precipitation of diabetes mellitus type 1 or type 2. Third, hypertriglyceridemia and hypercholesterolemia. Fourth, dental problems, including caries or tooth decay and chipped teeth. Some patients will go to the freezer and try to eat frozen pizza, for example. It's so inappropriate, but they're not fully awake. They don't know what they're doing that well. Fifth, allergic reaction from carelessly eating foods to which one is allergic. And sixth is secondary depression from loss of control. Now, sleep-related eating disorder emerges most commonly as a subtype of sleepwalking and restless leg syndrome, and also commonly emerges from sedative hypnotic use, with zolpidem being number one, and I will discuss this further. Key points: sleep-related eating disorder is a female-predominant disorder in most reported cases. Second, sleep-related eating disorder is often a variant of sleepwalking or restless leg syndrome, and also can be triggered by sedative hypnotic medications.